pretty similar. Yes, if you add up the numbers, it's 14 plus 2 plus 2, that's 18 versus 13. We had some higher grade 3 or higher toxicity, but it's not like night and day. I mean, these are comparable. So we felt that, because another criticism is, well, if you see chemoradiation and you need a salvage cystectomy, if you're one of those 30% of patients, have you limited that cystectomy? Are you subjecting yourself to undue level of risk and morbidity from that procedure? And this, which has just been published in the Journal of Urology, might suggest actually it's probably okay. We can probably do it well. So these are the last few slides. So when is a radical cystectomy really justified? I think radical cystectomy is a great treatment. Okay, I really do. What I do believe, though, is that patients should be presented with options, and they should be told about the pros and cons of either approach and whether those options are actually appropriate for them. And we were talking earlier about the questionnaire that gets to this sort of thing from the patient perspective. But so a radical cystectomy, I think, is justified as an option when chosen by the patient after a full discussion of the alternatives. I mean, I think it would be hard for anybody to argue against that. I do think that it's also the best first treatment for those at risk, a high risk of local failure. So I think that means those who have hydronephrosis, remember the backing up of the kidneys, or T4 disease, where actually the cancer is invading in the male, for example, into the prostate, or into organs around the bladder. I think surgery is a better upfront treatment. I was saying it's a better treatment if you have a really poor bladder function. If your bladder is not worth saving, then you shouldn't try saving it, period, right? And some patients have horrible bladder function, whether it's due to their tumor or some other reason, and maybe up front they're better served by having a cystectomy. And similar with bowel function. If you have really underlying bowel issues, radiation could make that worse. I also think a radical cystectomy is justified as salvage after chemoradiation if chemoradiation didn't work. Those 30% of patients where it might not. So combined modality treatment, by that I mean bladder-sparing therapy combined with some resection, chemo, and radiation, achieves a complete response and preserves the native bladder for the patient in around 70% of cases, while offering long-term survival comparable to contemporary radical cystectomy. Quality of life studies that I think I've shown have demonstrated that the retained native bladder functions well, and long-term toxicity of chemoradiation to pelvic organs is relatively low. The incidence of cystectomy performed for palliation of chemoradiation-related toxicity has been very low, meaning we created so many problems with our chemoradiation that you actually have to remove the bladder just to get rid, to deal with those problems that you create. That we really see rarely. The morbidity of a salvage cystectomy also appears pretty comparable to a primary cystectomy. I don't want to overstate that, but I think that was the data I was showing you, the comparison with the Memorial Sloan Kettering data. Next slide. Yep. So we feel, our group at MGH feels that these results support the acceptance of modern bladder-sparing trimodality therapy for selected patients. Selected, I underline that word, it's not for everyone, as a proven alternative to cystectomy. We're working on the best regimen still. That's what all these protocols are about, for the which chemoradiation can we do once-a-day radiation, that kind of stuff. And we're working on the molecular targeted therapy and the biomarkers that I mentioned earlier. And ultimately, and I believe this is my last slide, the contribution of selective bladder-sparing therapy to the quality of life of patients represents a unique opportunity for urologic surgeons, radiation oncologists, and medical oncologists to work hand in hand in a truly multidisciplinary effort in the interest of that patient.